And then there's your feeling about what the SMSA is for this.
Right. So like everything, scores are a guide, I think, or an approximation, or giving an indication of how difficult this may be. But like all scoring systems and a lot of classification systems, there are limitations to these. And what it doesn't do is differentiate a non-granular lesion from a granular lesion. And in general, the non-granular lesions have a degree of fibrosis. They also actually have much a higher risk of having submucosal invasive cancer, although there was no evidence or impression of this on this lesion. But that doesn't say it isn't going to be tricky. It isn't tricky because the access is not easy. It's tricky because there's a risk of submucosal fibrosis. And this may sometimes surprise people that what looks to be a really straightforward lesion becomes a really difficult lesion to remove. So when you see a non-granular lesion, you have to realize that the level of difficulty you're removing this lesion is likely to be greater. It doesn't always come off very easily. And you have to have a high index of suspicion of the possibility of underlying malignancy present in the lesion. So I don't think this is a true level 2. It's a kind of level 2+, or, you know, I think you'd approach this with a bit more caution.
Okay. I agree with that completely. So then just show the picture of the end for you.
Yeah.
And so this was the outcome with a tip coagulation and a complete resection, I think. So our opinion is it's for endoscopy, not for surgery, based upon all the things we discussed. And if you are an SMSA level 2, but I would say, let's be honest, 3 endoscopist, then you could safely and effectively remove this using EMR with snare tip soft coagulation margin afterwards. Okay, we're going to share the next video unless anyone has any comments on that.
Yeah.
Okay. They are Kudo, I believe the Kudo, so I'm going to go with it. Kudo type 3L, indeed. So this is going to be recurrence of a tubular adenoma, right?
Yeah.
Do we agree with that, John and Roland?
Yes.
Yeah, it looks like it. I mean, I think your blink reflex for the people looking at the screen is this doesn't look right. And if you freeze the screen there, David, you've got tethering, right? So all the folds are tethered into one place. Now, tethering occurs in 2 situations. In the benign situation where there is extreme fibrosis and you've got scar tissue just basically contracting down and pulling the folds and distorting the lumen. So the lumen is distorted. It's not your nice shaped circumferential folds. So it's either fibrosis or it's malignancy. So your history becomes really, really important. So if the patient's never had a previous polypectomy, I would shift my thinking towards malignancy until proven otherwise. But if there's a history of previous polypectomy, this is highly likely to be a recurrence on a scar, or rather than recurrence. And what you've got is regrowth at the site of the incomplete resection.
You're saying that because it's so big?
Yeah.
Yeah, that's fair enough to go. Of course, I guess it depends a little bit on the time course of how long ago it was, but indeed, yeah, absolutely, incomplete.
But the nomenclature is really interesting because it isn't recurrence. It was never took away in the first place, is the point. Polyps don't grow back if you remove them completely. So what we term recurrence is actually regrowth of residual tissue is what we really mean.
And a lot of people would use the term residual or recurrent adenoma, indeed. Yeah. Although, as you might have correctly pointed out there, more residual than recurrent.
Yeah.
Okay.
So I think we locally have identified poor visualization and photo documentation of the cecum. If you miss a lesion like this, you're asking for trouble. I think the problem is that the post-colonoscopy colorectal cancer stuff is like 3-4 years out is what we're auditing. But this lesion may not present as a cancer for 5 to 6 years or even longer. So I think, lesions like this may not cause a problem in the immediate future, but they will probably in the longer term.
It's interesting you say that, Roland, and I'll be interested to see what the pathology of this was indeed. So why don't we skip to that now? And if we use MBI, we can see it better even probably. If the endoscopist decides that MBI might not be a bad idea, no, it's going to cut it off. So here we have, it's probably wedged within the middle. Do you agree with that, John? Now you can see the whole thing?
Yes.
Okay, so indeed it's not very big, but I think, Roland, your point is completely valid. You could not see the whole thing and you need to do something else. Either have a cap on your scope or use a snare to see the whole thing. So now we see the whole thing. We see this is a 10 millimeter snare, as John described how to use a snare before to size it. This is not 10 millimeters in size. This is less than 10 millimeters in size.